Welcome, everyone. Welcome to the Cardiac and Vascular Physiology webinar of the Physiological Society. The focus today is on pathophysiology of spinal cord injury. We have two speakers today, Dr. Alex Williams and Dr. Christopher West, both based at the University of British Columbia in Canada. My name is Dr. Paolo Tamaro. I'm an associate professor in pharmacology at the University of Oxford, and I will be chairing the session today. So before I introduce our speakers, I have some brief housekeeping to go over. Our speakers will deliver a presentation, each of them a presentation, which will last for about 40 minutes in total. We will then have about 15 minutes for a Q&A session. If you would like to ask a question, please do submit your questions through the Q&A button that you can find at the bottom of your screen. Questions will be then directed to the speakers during the Q&A session. But please do feel free to submit your questions at any time, because I will be able to look at them during the presentations. Please do bear in mind that you can submit your questions anonymously if you prefer to do so. If not, please include your institution at the beginning of your question so that I can announce this with your name during the Q&A. So although we may not have time for all questions, we will do our very best to go through as many as possible. Another point I would like to make here is that you can also type your own answers or comments to the other attendees' questions. And finally, please note that this webinar is being recorded and it will be available to rewatch. Now, without any further ado, I'm truly very delighted to introduce our first speaker, Dr. Alex Williams. Dr. Williams is an integrative cardiovascular physiologist, and she is currently a postdoctoral research fellow at the International Collaboration on Repair Discoveries Research Center at the University of British Columbia. She's working with supervisors Dr. Chris West and Dr. Brian Kwong. Dr. Williams' current research centers on the cardiac consequences of spinal cord injury and whether clinical approaches that target the heart could prove effective for the hemodynamic management of the acute spinal cord injury. I think Alex has also a keen research interest in sex-related differences in cardiac dysfunction and the incidence and prevalence of cardiovascular disease in individuals with spinal cord injury. Now, without any further ado, I should really very much welcome Alex, who is going to talk about the acute impacts of spinal cord injury on the heart and the implications for hemodynamic management. Alex, we are very much looking forward to hearing all about this, and please do feel free to start your talk when you're ready.
Thanks so much for that intro, Paolo. So let me just make sure I get my screen set up and shared appropriately. Give me 1 second. So hopefully everyone can see that well. So again, Paolo introduced the title of my talk today. And just to quickly overview the aims of the webinar, let me just get my laser pointer going here. There we go. So our aims today are to outline the current state of knowledge regarding the cardiac consequences of traumatic spinal cord injuries, and then further discuss strategies that may optimize cardiovascular outcomes in individuals with spinal cord injury. So to start off the webinar today, I'm going to focus on the acute aspects related to those aims, and then Chris is going to take over and speak to the chronic setting of spinal cord injury. So I know we have a probably wider audience here who aren't necessarily experts in spinal cord injury, so I'm going to go over a bit of the background and what we know so far about the cardiovascular consequences of SPI in general. So while spinal cord injury is widely recognized as a condition that leads to life-altering paralysis, spinal cord injury can also critically impact the autonomic control of the cardiovascular system in a lesion-dependent manner. So specifically, in terms of the current literature to date, one second, that literature has largely focused on the vascular consequences of spinal cord injury, specifically because individuals with SCI have debilitating blood pressure dysregulation over the long term. So there are impacts not only, well, first of all, on resting blood pressure, and again, those impacts are lesion dependent. And we can see that very clearly here in this graph where we see blood pressure on the y-axis and the level of injury on the x. And as we move from a higher level or cervical injury down towards the lumbar injuries, we can see stark changes in the impacts on blood pressure, where those with higher level injuries have greater impacts on blood pressure at rest. Now, not only do they have changes in resting blood pressure, but we also see really important changes in the dynamic regulation of blood pressure. As such, individuals with spinal cord injury experience frequent bouts of orthostatic hypotension or large exaggerated drops in blood pressure that we see during postural tilt. So we can see blood pressure again on the y-axis here. And as an individual with high-level injury is tilted, they have that very large reduction to blood pressure over a short period of time. Now, when we look at an ambulatory blood pressure trace of an example from a patient over 24 hours, we can see that those episodes occur at multiple times a day. Now, not only do they experience orthostatic hypotension, but kind of on the other side of that blood pressure pendulum, they experience frequent bouts of autonomic dysreflexia or episodes of severe hypertension that can also be quite life-threatening in cases. So again, we see these in the ambulatory blood pressure graph where those can occur at multiple times per day. And again, autonomic dysreflexia is lesion dependent in that it affects those who have higher levels of injury. So when I speak to high level injuries today, I'll be speaking to anything that's at or above the 5th thoracic level. And that's because we have that's an important point at which we have a differentiation in the effects on the lower vasculature versus the upper body vasculature in the heart. So in those high level injuries, we see that even higher levels of injury, so those with cervical injuries have higher numbers of those dysreflexia events than those with relatively lower injuries at the thoracic level. So overall, we can see that blood pressure dysregulation can be quite problematic for these individuals. Now, in contrast to the large amount of data we have on the vascular changes in SCI, relatively less work has focused on the cardiac consequences of spinal cord injury. However, there is evidence to date that shows that the heart's contractile function and loading, so when I speak to loading, I'm speaking to preload or the initial stretch of the heart at the end of its filling phase, and afterload or the load against which the heart has to work to eject blood into the system. So we know that, at least in the chronic stage, contractile function and loading are altered in these individuals. And specifically, spinal cord injury can impact the direct sympathetic control of the heart, circulating catecholamines, and centrally mediated splanchnic vasoconstriction, which essentially impacts the amount of blood that returns back up to the heart. Now, again, those vary depending on the level of injury. One important thing to note, though, when we look at the schematic on the right is that although we have those variable sympathetic impacts, we see that the vagus nerve does not travel through the spinal cord, and as such, the parasympathetic control or vagal control of the heart is left intact in these individuals. So when we look at different lesion levels, at the higher level, the cervical spinal cord injuries, we see a near complete or complete loss of descending sympathetic control to the heart, a large reduction in circulating catecholamines, and a loss of that splanchnic vasoconstriction to increase the amount of blood volume coming back to the heart. But again, vagal control is left intact. When we go to the high thoracic injuries, we see the same effects, but maybe slightly to a lesser degree, depending on the level within that range. But then when we go below the T5 level, into the low thoracic and lumbar spinal cord injuries, we don't have those direct effects of SCI on the heart via changes in sympathetic control. So for the focus of today's talk, I'm really going to be speaking much more to the high-level injuries, again, those that are high thoracic or cervical. So while we clearly have a decent understanding of the general and chronic impacts of spinal cord injury on the heart, we've yet to understand the acute impacts of spinal cord injury on the heart, so within the first 48 hours after the injury. And furthermore, whether those cardiac consequences have implications for clinical management of high-level spinal cord injuries. So with that, I'd like to transition to the acute setting of spinal cord injury and how clinical approaches aim to mitigate the secondary injury cascade that occurs within the first initial hours after a traumatic SCI. So in the acute phase after an injury, the initial mechanical trauma to the spinal cord, shown here with these little lightning bolts, causes a secondary injury cascade within the cord. And that's characterized by hemorrhage, which we can see here, edema, ischemia, inflammation, and cell death. So in the acute setting of spinal cord injury, clinical neuroprotective approaches aim to reduce that secondary injury to the cord, principally by improving spinal cord perfusion. Now, spinal cord perfusion pressure is the difference between mean arterial pressure and intracranial pressure. However, given that intracranial pressure is much more difficult to manipulate, most clinical strategies have targeted mean arterial pressure in an effort to alter or improve spinal cord perfusion pressure. Now, when we look at MAP itself, MAP is the product of cardiac output and total peripheral resistance. So treatments that increase either of those factors would theoretically improve MAP and ideally spinal cord perfusion pressure. Now, presently, the most commonly utilized approach for neuroprotection is hemodynamic management. And that management most often is vasopressor-based, meaning that they're targeting the vasculature with vasopressor drugs to increase peripheral resistance and then increase MAP and ideally improve that perfusion pressure. However, and they use kind of a one-size-fits-all approach to increasing mean arterial pressure to a set target of about 85 millimeters of mercury or higher. Now, while this may seem relatively straightforward, achieving the target MAP with vasopressors can actually prove quite difficult in some patients. And there are also concerns about the perfusion profiles that this vasopressor treatment can produce. So here we've got 3 different profiles shown in these human data where at a lower MAP and then augmenting to a higher MAP with vasopressors, we see perfusion profiles that might not be advantageous to recovery or to improving outcomes in these individuals. So in this case, we've got a necrotic profile, a hyperperfused profile, and then a patchy perfused profile. So we're not seeing this ideal world of just improving perfusion homogeneously across the spinal cord. And then apart from these human data, there's experimental models of spinal cord injury that have actually shown that vasopressor therapy can exacerbate the hemorrhaging in the cord. So in this case, we see on the y-axis hemorrhage area and on the x-axis the time following injury. And this is just within the first hour after the injury. And when norepinephrine is administered here, we see those animals getting the vasopressor therapy have much larger increases to their hemorrhage area in comparison to those animals that don't receive that hemodynamic management. So this is quite concerning and actually has been reported in multiple cases in experimental models over the years. So this brings to question, are there alternative strategies that might optimize hemodynamic management? So clinically, the heart's almost been entirely overlooked as a target for hemodynamic management, whereby potentially focusing on augmenting the heart's systolic function and cardiac output, rather than just focusing on total peripheral resistance, might more effectively improve spinal cord perfusion and hemodynamics compared to vasopressor therapies. Now, to look into this, we need an appropriate experimental model to interrogate both the cardiovascular system and spinal cord hemodynamics and spinal cord injury. So what models can we use here to ideally interrogate these questions? Well, this brings us to our group's large animal model or pig model of spinal cord injury. And the pig model is especially advantageous to other smaller models in that not only does it have similar cardiovascular physiology to humans, but the caliber of the spinal cord is much larger in that it allows us to instrument and invasively measure spinal cord hemodynamics and oxygenation and metabolism. So to interrogate specifically the cardiac consequences of high thoracic spinal cord injuries, we've collaborated really closely with Dr. Brian Kwan's group at UBC to adapt his well-known T10 model into a T2 model, which would impair the descending sympathetic control of the heart so that we can look at the cardiac consequences of spinal cord injury. So when we compare those models, just looking at hemodynamics alone and also at the hormonal responses, we see that the T2 model does show very different responses from the T10 model. So we have now an effective model where we can interrogate the cardiac consequences of spinal cord injury. So with that model now available to us, we can ask a few key questions in regards to acute SCI. So our first question was, what are the acute impacts of high thoracic spinal cord injury on the heart? And then, can cardiac-focused hemodynamic management optimize hemodynamics and mitigate secondary injury in the spinal cord? So this brings us to the first of two studies that I'm going to show you today. The first study aimed to determine the acute impacts, so within the first 4 hours, of high-level spinal cord injuries on left ventricular contractility and sign model of T2 SCI. So, as mentioned, this model allows us to do quite a bit of instrumentation. And for this study, and the next study I'll show, we did direct catheterization of the heart, where we were able to, first of all, advance a left ventricular pressure volume catheter, shown here, into the left ventricle to get pressure and volume data in real time, which I'll show you shortly. We also advanced a Swan-Ganz catheter into the right heart and placed it in the pulmonary artery, which allows us to measure pulmonary pressures and also lets us do the gold standard measures of cardiac output with thermodilution. We also had an inferior vena cava occlusion catheter placed just below the heart, and I'll show in the next slide why that's really important for what we're doing. And then we had bilateral femoral mean arterial pressure, or sorry, arterial pressure catheters to monitor mean arterial pressure throughout our experiments. Now, the left ventricular pressure volume catheterization is especially useful to us in that we can assess different aspects of cardiac function. So first, I'll just orientate you to what these loops actually mean. The loop represents one cardiac cycle. So at the end of the cardiac cycle, as the heart's filling, we see an increase in volume, which is on the x-axis here. As the heart starts to generate pressure before ejection, we see the pressure on the y-axis go up. As the heart's now ejecting blood, we have a reduction in that volume. And then at the end of the systolic phase, when ejection is finished, the heart begins to relax and we have that drop in blood pressure back to the next part of the cycle. So that's what we're looking at here when we look at our loops. So we can measure different aspects of cardiac function. The first being load-dependent data. And what I mean by load-dependent is that it can be influenced by preload and afterload, as I mentioned earlier. And here we can get measures of pressure data, volume data. We've got stroke volume here as the width of the loop, in addition to other measures like arterial elastance, which isn't shown here, but gives us a good index of afterload on the heart. Now, in addition to that, we can get load-independent data, meaning that these are intrinsic functions of the heart. And we can't just measure them with one cardiac cycle or one loop. What we need to do is get a number of loops across a span of volumes. So what we do to accomplish that is we perform IVC occlusions, where we inflate a small balloon at the end of that catheter to reduce the amount of blood transiently that comes back up to the heart. And that gives us a nice gradation of loops across a range of volumes. And with that, we can draw a line through these end systolic points here. And that slope gives us an index of left ventricular contractility. So you'll see EES throughout this presentation, and that's referring to our measure of contractility using the pressure volume catheterization. So following that catheterization, what we did with the animals was performed a laminectomy to expose the spinal cord. And from there, set up a rail setup where basically this rail was attached to the pedicles of the spine. And then there is an impactor here with about 50 grams of weight that is dropped 20 centimeters onto the spinal cord to perform a contusion injury. So for the spinal cord injury, we have that weight drop, and then we add an additional 100 grams on top of that to further compress the spinal cord. And we leave that compression on for 2 hours. And then after that 2 hours, the additional weight and the impactor are removed. And we collect data for another 2 hours after that. So in total, we performed hemodynamic monitoring in these animals, obviously at baseline prior to the injury, and then up to 4 hours following the spinal cord injury. And we performed hourly IVC occlusions to measure contractility in those animals. So here we've got representative traces of those IVC occlusions at baseline. And while this is a representative trace here, the data I'm showing you here in numbers are the means from 8 animals in this study. And again, just to orientate you to our question here, I'll remind you the question that say was, is left ventricular contractility acutely impaired in high-level spinal cord injury? And then as compared to baseline, when we look at contractility and systolic elastance at 1 hour here and at 4 hours, we can see very clearly that left ventricular contractility is reduced after our T2 injury. And again, those are representative traces. When we look at the group data, we can see with the individual data shown here as well, that consistently we see reductions in end systolic elastance at 1 hour post-injury, and those persist up to 4 hours following SCI. So here we've confirmed that yes, contractility is impaired in the first hours post-SCI, likely due to that loss of descending sympathetic input to the heart. So that led us to our next question in the second study, where we aimed to examine, now that we knew that contractility was impaired acutely, we aimed to examine the efficacy of a cardiac-focused hemodynamic management or used dobutamine, which is a cardiac inotrope and beta agonist, in contrast to vasopressor therapy with norepinephrine to improve spinal cord oxygenation and hemodynamics, again in that acute T2 model of spinal cord injury. So for our experimental setup here, we had 3 key groups going into it. We had our control group that received no management, a norepinephrine group, and a dobutamine group. And we randomized the intervention amongst the animals in the norepinephrine and dobutamine groups. What we did for hemodynamic management was we wanted to kind of relate to what's occurring clinically. So for norepi, what we did was we targeted a map by continuously titrating our drug infusions to hit that map of 85 to 90, which is the clinical goal usually. We wanted to do something similar with dobutamine, but that hasn't been done clinically. So we decided it would be probably most appropriate to target a normal baseline contractility with the dobutamine infusion. So what we did was we took our baseline contractility from our first study in the uninjured animals prior to the injury and used that as our guide and range that we wanted to target for the dobutamine infusion. Interestingly, what happened there was when we gave the dobutamine infusion and performed the injury, only 4 animals got substantial or sufficient doses of dobutamine, around 2.5 mg per kilo per minute, whereas 3 of them got very minimal doses. And that's because those 3 animals started at relatively higher end systolic elastances at baseline compared to our first study. So they did have a reduction in contractility, but it wasn't enough for them to drop well below our target. So because we had already decided on that target, they didn't get very much drug. So for the rest of these results, you'll see all of the groups shown as norepinephrine in orange. The high dose dobutamine group will be in green, and the low dose dobutamine group will be in blue. So for this trial, the experimental timeline was the same as the last study, only we added in the hemodynamic management, which began at 30 minutes and continued and was continually titrated up to the 4 hours post-injury. And then our spinal cord injury was performed similarly to in the last study, where we had that T2 contusion injury with a total of 150 grams compression over 2 hours, after which we took the compression off. And then we instrumented the cardiovascular system, similarly again to the last study, but in this one we added additional measures where we were monitoring spinal cord measures. Specifically, our group has this setup where we have a guide where we can insert intraparenchymal sensors into the spinal cord at different points across the spinal cord to assess hemodynamics, spinal cord oxygenation, blood flow, and also perform microdialysis measures of spinal cord metabolism. So you can see here we've got 2 sets of probes, one at the 1.2 and one at 3.2 centimeters caudal to the impactor. Today I'm going to just show you the 1.2 centimeter data. All right, so again, to orientate you back to our question for the study, just so it stays nice and clear, we wanted to know, can cardiocentric management with dobutamine improve hemodynamics, spinal cord oxygenation, and histological outcomes compared to norepinephrine? So when we're looking at these data, I'll just mention that these stats for each group are a within group comparison over time compared to the pre-management measure, so just before hemodynamic management begun. And then any letters denote significant differences between the groups. So what we've got here is the mean arterial pressure, and not surprisingly, because we targeted MAP with norepinephrine, we see an increase in MAP with that treatment. But although we didn't target MAP with dobutamine, we still saw that dobutamine was effective in improving mean arterial pressure in those animals, especially in the high dose group. Then when we looked at contractility, again, not surprisingly, contractility increased in those animals that received dobutamine because it was our target. But we did also see increases to end-systolic elastance in the norepinephrine group. Now, what's really interesting, though, is that while they both increased MAP and end-systolic elastance, there were differential effects on the heart. So it's a bit harder to see in this case, but the stats show you that the norepinephrine group only had increases to arterial elastance, which I mentioned is our index of afterload on the heart. So the heart has to work harder to eject blood into the system, which is a bit concerning because the spinal cord injury has already essentially impaired contractile function to the heart. And then when we looked at the actual hemodynamic effects of that, we see that both stroke volume and cardiac output only increased in the dobutamine group with higher doses and not in the norepinephrine group. So while mean arterial pressure and contractility are increased with both dobutamine and norepi, only dobutamine improves cardiac output. So we can see that it has a beneficial effect on the heart's hemodynamics that potentially support improved MAP and potentially improved perfusion. So we can say that yes, dobutamine does improve hemodynamics more effectively and appropriately than norepinephrine when we look at the heart. Now, when we look at our intraparenchymal spinal cord data, we've got spinal cord oxygenation here on the y-axis. And what we saw was, and you can see quite clearly here, that dobutamine was quite effective in improving spinal cord oxygenation. And when we express those data as a percent change from baseline, we see that dobutamine improved that oxygenation to a greater extent than any of the other groups, which was quite exciting to see. And then in addition, when we looked at our metabolic data, we had a lactate over pyruvate ratio to look at the relative increases in anaerobic metabolism. And you see that that increases quite significantly here in the norepinephrine group. But that increase appears to be blunted in the dobutamine group, potentially because we have improved oxygen delivery to that area. So here we've shown that yes, dobutamine does improve spinal cord oxygenation and metabolism more effectively than the norepinephrine vasopressor treatment, excuse me. And finally, when we looked at our histological data, those were also very, very stark and clear. So we've got example sections from the control group, the high-dose dobutamine group, and the norepinephrine group here. And you can see in these examples that, as I mentioned before in the studies shown previously, that we do see exacerbated hemorrhage in the norepinephrine group. And such hemorrhage does appear to be mitigated, at least partially, in the dobutamine group. And when we look at the group data, we do see that there was significant hemorrhaging in the norepinephrine group. Again, this agrees with multiple experimental models that have shown this in the past, whereas dobutamine did not significantly increase hemorrhage and at least partially mitigated those that exacerbation to hemorrhaging. So we can see here that we see improved histological outcomes also with dobutamine in comparison to norepinephrine. So in summary from those studies, we have found in the acute setting of spinal cord injury that's high level, or in our case at the T2 level, we found first that cardiac contractility is impaired within the first hour following injury, and that is likely due to a loss of descending sympathetic input to the heart. Then in our second study, we found that the cardiac-focused hemodynamic management using higher doses of dobutamine appears more effective than traditional vasopressors for that T2 spinal cord injury treatment. So we saw both improved MAP and cardiac output in dobutamine. We didn't see improvements to cardiac output or stroke volume in the norepi group, likely because of that increase in afterload, which we should consider going forward because it is a bit concerning. We also saw improved spinal cord oxygenation and metabolism with dobutamine as compared to norepi. And again, reductions or at least partial mitigation of the spinal cord hemorrhaging that we see with vasopressors. So with that, I'd like to thank all of our teams, because all of this work takes a lot of people with a lot of dedication. And with that, I'll pass it on to Chris.
Many thanks, Alex, for presenting us this really cutting-edge research. It was presented extremely clearly. It's a fantastic, fantastic talk, fantastic story. I'm sure there will be questions for you in the Q&A sessions. I would like now to introduce our second speaker today, Dr. Christopher West. Dr. West is an assistant professor in the Department of Cell and Physiological Sciences within the Faculty of Medicine at the UBC. Prior to this, Dr. West gained a PhD from Brunel University in the UK and undertook postdoctoral training at the University of British Columbia, where he's now based. Dr. West's research aims to understand the pathways that control cardiorespiratory and autonomic function after spinal cord injury, and how to effectively manipulate these pathways to improve the functions of these systems for therapeutic benefits. Chris's lab utilizes a combination of approaches, combining preclinical animal models with also studies involving individuals, human subjects, athletes as well, with spinal cord injury to enable a translational approach to their research. Dr. West has discovered that the heart undergoes a rapid and sustained remodeling after spinal cord injury, and this leads to a reduced systolic function and also cardiomyocyte atrophy. And these changes have, of course, implications for spinal cord perfusion, exercise tolerance, and cardiometabolic disease. And Dr. West today is going to give a talk entitled Changes to the Heart in the Chronic Phase Post-Injury and the Implications for Exercise. Chris, we are hugely looking forward to your talk. Please feel free to start when you're ready.
Okay, thank you very much for the introduction, and it's a real pleasure to be here giving this talk today. I want to start off by just acknowledging that most of the data I'm going to share today has been from really outstanding graduate and postgraduate students that I've been fortunate to have in the lab. They've really helped propel the quality of the research that we've been able to complete over the last few years. So I'm going to take the other end of the spectrum, whereas Alex spoke to you about the acute effects of spinal cord injury. I'm going to talk about what happens at the other end of the chronic stages. And so there's been a fair few studies that have looked at cardiac function in the chronic stages post spinal cord injury. Most of these have done it cross-sectionally using echocardiography. So a few years ago now, myself and Alex and a graduate student in my lab set out to effectively conduct a meta-analysis of all of the studies that have looked at cardiac function using echocardiography. And what this overview here shows is that, perhaps unsurprising, now you've heard Alex's talk, is if we just take a look at some of the main volumetric indices for the heart, so end diastolic volume or the diameter of the left ventricle at end diastole, they are significantly reduced by about 20% after spinal cord injury. This is associated with a reduction in mass and stroke volume. But if we look at ejection fraction, which is our typical indice of contractile function in the clinical setting, we actually find no difference. But we suspect that is no difference because the heart is getting smaller after spinal cord injury, and that, of course, is used in the measurement of ejection fraction. So whilst this data tells us quite nicely about what's happening with structure and volumes, it also raises a number of questions. Firstly, what happens to contractility in the chronic setting? Is it really unchanged like ejection fraction would suggest? What happens at the level of the cardiomyocyte? How long do these changes take to occur in both structure and function? What is the underlying stimulus for these changes? And then what can we do, I'll put in quotations here, to treat this, this reduced function? So these are some of the questions that my lab's been trying to answer for the last 6 or 7 years now, and I'd like to share some data on these topics with you today. So if we just take a revisit back to some of the neuroanatomy that's important in controlling cardiac function, we know that from the brainstem where the cardiovascular center sits, there's these descending sympathoexcitatory neurons that synapse onto a sympathetic preganglionic neuron. They exit the spinal cord. They will synapse in a paravertebral or prevertebral ganglia before the postganglionic neuron goes on to the target organ. Now, some of these fibers will go to the heart itself. Other fibers will innervate the blood vessels, which will have an indirect effect on cardiac function because it will change things like blood pressure and venous return. The important thing to note, as alluded to by Alex, is that the fibers that control the heart and blood vessels exit in the thoracic spinal cord. So in order to answer some of these questions, we set out to try and develop a preclinical model that we could take into the chronic setting. And we did this by using a rodent model, and we did the injury right at the top of the thoracic spinal cord. So for all intents and purposes, for the remainder of this talk, we're going to be talking about a situation where the sympathetic preganglionic neurons are disconnected from brainstem control. We focused on the rodent for a number of reasons. Number one, its practicality and cost. There's less ethical implications than using large animals. And from a neuroanatomical perspective, the anatomy that controls cardiac function in the rat is actually remarkably similar to the humans, albeit obviously the heart size is a little different. And so to answer some of these questions, we essentially set out to take a reasonably straightforward approach to this, where we would take our rodent model, and then we would track changes in the heart using high frequency echocardiography. We're also able to put the pressure transducer into the left ventricle, just like Alex showed in the pigs. We can do this in the rats as well. And then of course, we can actually take samples from the heart itself and look at histological changes in the cardiomyocytes. So for those unfamiliar with this type of technology, this is exactly the same as what you'd see in humans, except now put onto a smaller scale and a much higher frequency. So there exists some very high frame rate echocardiography machines now, which enable us to get a pretty clear picture of the left ventricle in long axis. And therefore we can use this to non-invasively track changes over time. The second way that we can do this, as Alex showed, is a little more invasive. We can actually take our rodent model of spinal cord injury, we can intubate it, ventilate it, and then keeping the chest closed, we can place a catheter into the left ventricle via the carotid artery. We can also dissect down into the abdominal cavity to access the inferior vena cava, and therefore create these pressure volume loops or series of pressure volume loops in the rat, just like we can in the pig. And this enables us to get a measure of contractile function in vivo. And then the third thing we've been able to do is we've developed a way using a quadruple immunofluorescence stain where we can take sections of the left ventricle and then we can stain individual cardiomyocytes such that we can make measurements of things like cardiomyocyte length, cardiomyocyte width. We can now do cross-sectional area. And so we can get a rudimentary estimation of cardiomyocyte volume and how that changes with time or with different interventions. And so one of the first sets of data I'd like to share is just taking what we know from Alex is okay, we've seen the functional changes might happen quite quickly, but what happens to structure and function after those first few hours post-injury? So we set out to answer this by conducting either a sham injury or a high thoracic spinal cord injury in our rodent model. We then had some animals that survived for the first 7 days, and we tracked them using echocardiography. We had other animals where we sacrificed them at different time points post-injury so we could do our left ventricular catheterization. And then in all animals, we were able to do some histological analysis at the end point in each of these groups so that we can track over time how these structural and functional indices are changing. So this is the data of Mary Fussy, who just completed her master's degree in my lab and is now a PhD student. So essentially for her master's degree, she set out to take some sham injured rats and spinal cord injured rats. We imaged the same rats over time for 7 days. And then in a separate study, we did a chronic study where we took rats out to 8 weeks. And here's just some example echocardiography images. I think what you can see quite nicely is the left ventricle, which is shown in this shape here, is getting much smaller already quite quickly after spinal cord injury and stays persistently smaller out to the 8-week time point. If we take some of those key indices of cardiac volumes, we can see this quite nicely. So the blue line now is reflective of the spinal cord injured group. The black line is the uninjured group. And what you can see quite nicely is that in the injured group, there is this gradual decline in end diastolic volume, stroke volume, and cardiac output. It declines over the first week post-injury and then stays persistently declined to the 8-week time point. From a functional perspective, what I'm showing you now is group mean ensemble average pressure volume loops. So the shape of these are going to be a little funky because every rat has a slightly different shape or reaches end diastole at a slightly different point. But this is actual group mean data now. So we're able to look with error bars as well what happens. And what you can see that's very apparent is that already on day 1 post-injury, you see a reduction in the pressure, so the height of this loop. But the volume of this loop isn't changed in the very acute setting. It's out to about a week, and then that persists to 8 weeks where the volume of the heart is changed. If we use those inferior vena cava occlusions to plot the end systolic elastance, you can appreciate quite nicely in these examples that already the gradient of this line is reduced by 1 day and is persistently reduced to 8 weeks. And if we quantify this, which is the EES, the end systolic elastance here, our measure of contractility, again, similar to what Alex showed, it's immediately reduced and it is persistently reduced out to 8 weeks post-spinal cord injury. In fact, if we take any of the pressure-related indices off of the PV loop, we see this immediate reduction following spinal cord injury. In terms of mean arterial pressure and peripheral hemodynamics, that doesn't drop immediately post-spinal cord injury. This is because cardiac output has not dropped in these first 3 days, but the reduction in MAP is coincidental with the drop in cardiac output, which starts to occur around 5 to 6 days post-injury, and then is persistently reduced out to 8 weeks. From a histological perspective, so to orientate you to the figure, we're able to look at the cardiomyocytes in 2 different orientations. We can look at longitudinal orientated cardiomyocytes, and then we can look the other way and we can actually circle the cross-sectional area of cardiomyocytes. To do this, we do 4 different stains on the tissue. So one is connexin 43, which will stain the end plates between cardiomyocytes. We use alpha-actininin, which is a Z-line protein, to measure the width. We use wheat germ agglutinin, which allows us to demarcate the cardiomyocytes, and then Hulk staining to make sure we have nuclei visible to make sure it is a cardiomyocyte that we have stained in the right orientation. Now, when we did this, I'm going to try and just keep the data relatively straightforward and show you only 7-day data and the 8-week data. The way we show our data is actually to circle about 80 to 100 cardiomyocytes per animal, and then we express those as a frequency. So here, for example, in the bottom left, this would be the frequency of lengths. So if you have a leftward shift of this frequency histogram, that means that the width or the length is getting smaller. And actually, over the first 7 days post-injury, we see no significant changes in the structure of the cardiomyocytes. By 8 weeks post-injury, there is a leftward shift, certainly on the width and to an extent on the length of the cardiomyocytes, suggesting that there is cardiomyocyte atrophy present. In the chronic stages post-injury, but not in the acute stages. And so we have a situation here where we have a rapid reduction in functional changes in the heart post-spinal cord injury, and they precede the structural changes. So what I want to do now is just talk a little bit about some of the implications of these changes. You'll have to bear with me as I take a bit of leap of faith here that what happens in the rat happens in the human. But if we take a human with spinal cord injury and we have them in the seated position, in the supine position, and then we move them up to the seated position, because there is no direct sympathetic innervation to the heart, and because we've lost that sympathetic innervation to the blood vessels, what happens is that we get an exaggerated drop in end diastolic volume, stroke volume, and cardiac output, and this causes blood pressure to fall. So people with a high-level spinal cord injury have a really significant risk for orthostatic intolerance. Many of them, in fact, can faint during this transfer process. The other thing that's quite remarkable is if you look at some of these volumetric indices during exercise, so you take someone with cervical spinal cord injury and exercise them, if you look at the stroke volume response, it's basically a flat line. Stroke volume does not go up during exercise in someone with spinal cord injury. Of course, if you take able-bodied individuals and exercise them at the same power output, we see this nice increase in stroke volume. Cardiac output goes up a little bit because we have vagal withdrawal, but really not very much at all. So for those not familiar with working in this field, just take a moment to think about what it would be like if you went out to exercise and your cardiac output really didn't increase. This is quite a significant limitation for the demand you can put on your system during exercise. And so I just want to spend the last few minutes here sharing some ideas that we've had in the lab about how we can target some of these changes and what we can do to improve function. I'm going to share some data in both rats and humans here. So if we go back to the neuroanatomy, theoretically, there's 4 different sites that we could choose to manipulate to try and improve function of the heart. We could target the descending sympathoexcitatory fibers. We could target the sympathetic preganglionic neuron, the postganglionic neuron, or the target organ itself. The other thing we could do is actually think about blood coming back to the heart, because these, because the sympathetic preganglionic neurons that go out to the vessels are also devoid of input from the RVLM, it means that we get a lot of blood pooling in the abdomen. And this is one of the reasons why stroke volume can be so low. So really you've got these 2 competing mechanisms that we can target. And in the interest of time, I'll just share one example from each of these targets. So this is some of the work done by one of my PhD students in the lab at the time. And what we did was we took one of the main neuroprotective drugs that's been used in the field of spinal cord injury, minocycline, which has been shown to be able to preserve descending motor pathways and ascending sensory pathways, but no one had really ever looked to see if minocycline could be used to preserve descending sympathetic pathways. We took our 2 groups of rats and either gave them a vehicle injection or minocycline for the first 2 weeks, survived them out to 8 weeks, and then we did our terminal catheterization procedures to look at the effect on cardiac function. The theory is if we give minocycline, we can preserve more fibers through the injury site and therefore preserve cardiac function. So if we take a look at some of the immunofluorescent staining, we can actually see here that if we quantify lesions, so you've got the spinal cord horizontally, and then we have 2 stains going on, one just a GFAP stain, and the other is tyrosine hydroxylase, which is the rate limiting step in catecholamine synthesis. So by staining for tyrosine hydroxylase, it gives us a marker of descending sympathoexcitatory fibers. And if we look in minocycline, we see a reduced lesion area compared to vehicle, and we see a almost 4-fold increase in the preservation of descending sympathetic axons. So the question now becomes that if we are able to preserve these descending sympathetic axons or fibers, what happens to cardiac function? Well, here's that measure of the end systolic elastins. You can see we're almost able to normalize cardiac function with minocycline, suggesting that you really don't actually need to preserve too many fibers in order to be able to have normal cardiac function. We've translated this a little bit to humans in some work that I've done in collaboration with Aaron Phillips, where we actually took people with spinal cord injury that have an epidural stimulator implanted. So rather than preserving the descending pathways, we're now able to activate those pathways which remain after spinal cord injury, but that are dormant because of no input from the RVLM. If we turn that epidural stimulator on the spinal cord, we're able to activate the sympathetic preganglionic neurons, And if we do the same tilt test, so take someone from supine, if we sit them up, these indices of cardiac function drop. If we turn the stimulator on when we sit them up, we can almost abrogate or prevent this reduction in all of our volumetric indices. This has some pretty profound clinical implications. If you look at the blood pressure response to tilt, without the stimulator on, there is severe orthostatic intolerance, and we can almost completely get rid of this with the stimulator on. So both our animal and human data suggest if you can target the descending sympathetic pathways, you can have some luck in restoring normal cardiac function. The other thing we've done is try to modulate venous return. For this, we've used exercise. So in this study, we took our rat model of spinal cord injury. We did 2 different exercise paradigms, either hind limb cycling to move the blood volume that's pulled in the legs back up towards the heart, or a control of just upper limb exercise, for which we used swimming. So these, again, are spinal cord injured rats that we put through this. What we found is, if you look at the passive hind limb cycling group, so this group here, the width of this loop increased. So we were able to successfully restore stroke volume, but in no animals was there an increase in either the pressure generating capacity of the heart or contractility. Not really too surprising because we didn't activate the sympathetic nervous system. And again, this is a different mechanism of action, but some evidence that we can increase stroke volume and cardiac output by increasing or by mobilizing the blood volume in the lower limbs. We've just finished the translation of this work to humans. This is work of Gevorg, another master's student in my lab, where he took humans with spinal cord injury and put them through one of 2 different exercise paradigms. So either of these, you are asking the person with spinal cord injury to either flex and extend their arms in a backwards forwards motion with their legs attached to this. And because the legs are attached on the same crank, you have active arm exercise with passive leg exercise. We can also do this the same way, but in a cyclical motion. So moving the arms cyclically, legs are connected onto the same crank, which again will move the legs around passively. So we call this active arm, passive leg exercise. We very simply took a number of individuals, put them through maximal incremental exercise or submaximal incremental exercise. In the interest of time, I'll just show one of the sets of data. But what we found is if you look at VO2 peak, it was increased in every single participant when they did the exercise that involved passively moving the lower limbs. And whilst we couldn't measure stroke volume directly, there was no change in heart rate between the modalities, and there was an increase in oxygen pulse, suggesting that the way this works is probably by moving the blood volume back up to the heart and increasing stroke volume. So just bringing this together, I think we have some good evidence now that spinal cord injury causes chronic reductions in cardiac contractility and cardiomyocyte size. And these changes to the heart likely underpin the impaired ability to respond appropriately when challenged. So things like exercise or an orthostatic challenge. Interventions that can target the descending spinal pathways are probably the most effective means of modulating and improving at least cardiac contractile function. And then lower limb exercise combined with upper limb exercise is a way that you don't target contractility per se, but you are able to increase stroke volume and cardiac output. And so over time, if you were to repeat this, it probably has some important implications for exercise prescription. So with that, I'd like to thank the funders, all of my mentors that have been really instrumental in helping me get to this place, and then all of the people that have been in my lab. Thank you.
Chris, thank you very much for your talk. Truly exciting, cutting-edge research. And I think we have a few moments now for questions from the attendees, from the audience. Perhaps we can start. We may be able to go through them all. There is a question first of all from Kirandeep Kaur. For Alex, a question for Alex is about how can we find increased blood pressure is due to spinal cord injury only? Alex, I wonder if you can offer your thoughts to this question.
I'm assuming they're speaking to the autonomic dysreflexia events. That has been shown experimentally, I'm sure, in animal models where they use different stimuli to actually evoke those events. And those are things that occur with a high level of injury, but wouldn't occur in an uninjured animal. And there's been quite a bit of work that's characterized the actual pathways that are impacted and that kind of alter their signaling following the spinal cord injury that lead to those autonomic dysreflexia events. So long answer short, we have a lot of experimental models to show that that's specific to spinal cord injury.
That's great. Perhaps I can ask a quick follow-up question, if I may, is about the, yes, this regulation of blood pressure. There is surely a component due to the, also to the vasculature. I wonder if the perhaps baroreceptors may also be affected during those acute changes, and whether that is an important aspect of changes in blood pressure.
It's a very good question. And yes, absolutely, the baroreceptor reflex is impacted. And especially at those high-level injuries, we lose, at least partially, if not fully, that descending sympathetic control to the heart and the vasculature below that level of injury. So those impacts are more pronounced with higher lesions. We do still have, as I mentioned earlier, that vagal control that's intact. So you still have some chronotropic control of the heart for the baroreflex. But in terms of augmenting cardiac output via a sympathetic pathway, that's lost in those higher level injuries, or at least highly. Yeah.
Yeah, thank you. That's very useful. And we have other questions here. Alex, great webinar. What made your team reach the effects of dobutamine on spinal cord injury over other cardiac medications? So this is a question about the selection of dobutamine, I suppose, for your studies.
I guess the real answer to that is I came into the field of spinal cord injury with a cardiac expertise and as such a cardiac bias. So when we were looking at different alternatives, we were considering potentially improving cardiac output by some kind of infusion to increase blood volume. But then from a clinical approach, I kind of thought dobutamine is clinically widely used and has the same, if not less, cardiac side effects as norepinephrine. So it seemed like a simple and easily implementable drug to use that would allow us to really kind of focus in on improving MAP via the heart rather than something that would target other parts of the vasculature, if that makes sense.
Yeah. Yes, thank you, Alex. I think it's a very valid point from my point of view. And I can see many other interesting questions. Sangam Gurun is asking about things, the information about the acute spinal cord injury is truly beautiful, defined as such. However, is there any difference in terms of age as porcine model was used? And is it the same mechanism when you consider syringomyelia?
So in terms of our model for the acute injuries, those animals are all of the same age, relatively. I think they're several months old, so they're not old. They're younger, healthier animals. We haven't looked at using an older pig yet, but I believe that what they mentioned in the question isn't actually a traumatic spinal cord injury. That's a non-traumatic spinal cord injury where you have progressive impacts on the spinal cord based on that disease process itself. So in our model, we wouldn't necessarily be looking at that. But I do imagine, given that the autonomic control of the cardiovascular system is impacted by age and changes over time, that could be something that might affect any changes in a spinal cord injury. I don't know if
and then perhaps if I can just add, in terms of syringomyelia, it's probably the same mechanism. So for those that don't know, that's a cyst formation in the spinal cord that will that's called a syrinx, and it will elongate over time and destroy the spinal cord tissue. So it's more progressive. There's not been anywhere near as much research done in these kind of progressive spinal cord diseases versus traumatic spinal cord injury. But there's certainly evidence of things like autonomic dysreflexia and blood pressure instability that occurs in syringomyelia. I'm not aware of any studies that have targeted the heart itself, but essentially if it's destroying the spinal cord tissue, certainly around the areas where those descending sympathetic pathways are, we would expect a similar autonomic profile as that progresses.
Absolutely. There are some other interesting questions. We have a question from John Stavers from the Penn State University, Pennsylvania, US. The question is, Alex, if you have any data comparing the completeness of injury or percentage of axonal damage following the DOB treatment or the noradrenaline treatment in these pigs. In other words, can you show that the improved perfusion oxygenation achieved with cardiocentric treatment was also effective in mitigating secondary injury?
I'll answer first, and if Chris wants to add anything, he's more than welcome to. In terms of the additional measures of secondary injury, we did also perform staining for GFAP and IBA to look at inflammation in the cord, and we didn't see any significant differences within that acute phase following that. We didn't specifically measure axonal sparing, so we don't have that for those data yet. But that is something we're heavily considering in future studies using the same model.
Yeah, I'll just add, we have a second study that is ongoing at the moment that is taking the pigs that have had these acute interventions out to a 12-week time point. Within those first 4 hours, there isn't sufficient time for lesion development. So we haven't been able to effectively determine whether this acute treatment yet changes the lesion volume or in terms of motor outcomes, but we have a chronic study that is ongoing. We're only about halfway through it. We should have been further through, but COVID-19 closed our lab down, so we're not as far through it as we would have liked to have been, but we're answering that question in the chronic model.
Perhaps another quick follow-up question, if I may. So in your models of acute and also chronic, are there also changes in the respiratory rate and respiratory function in any way that could in some way impact or influence your interpretation of the improvement in oxygenation of the spinal cord fluid? So I'm wondering whether that is also an important parameter that you may be interesting to consider in your research. Alex, especially I'm actually quite intrigued by what happens acutely during the damage to the spinal cord, to the higher level of the spinal cord that you produce. What happens to the respiratory rate and the respiratory aspects of respiratory function, if you have looked into that?
I don't mind answering that one. So in terms of our injury model, we're injuring typically around the T1, T2, T3 segment. The diaphragm, the primary muscle of inspiration, is innervated at C3 to C5. So there is definitely respiratory changes after a high thoracic spinal cord injury, and the same in humans. They tend to affect expiratory function more than inspiratory function. So you have to have an injury up at about the C3 or C4 level before inspiration is very severely reduced. So if you take humans with a C6, C7, C8 injury, most of them can breathe spontaneously. They don't require ventilation. Their inspiratory pressures are relatively well preserved. They only lose the inspiratory intercostal innervation. The rest of the inspiratory muscles are preserved. But from an expiratory function, those expiratory muscles are certainly lost of control. The maximal expiratory pressures around 50% of predicted. And actually one of the other PhD students in the lab looked at this for his whole PhD, where he looked at interactions and implications of changes in lung function for the heart. And what we've been able to show is that when you lose the expiratory muscle function, it causes dynamic hyperinflation in these individuals. So they breathe higher up in their lung volume, and that can negatively impact cardiac filling through both, mainly through series ventricular interaction. So there's definitely some crosstalk between the respiratory and cardiovascular systems. In terms of our model, we think the loss of descending sympathetic input is probably more important, just because the model is in the thoracic region, and at that region, inspiration is relatively well preserved.
Brilliant. Yeah, thank you, very useful. A few other questions may be interesting to address. So the question from an undergraduate student from the University of East London, Sangam Gurun, in terms of orthostatic intolerance, was there any time limit in positioning the subject from supine to sitting position?
Yes, we typically would move someone from, we would keep someone supine usually for actually 30 minutes and make sure we have full hemodynamic stabilization. And then typically when we do our tilt tests, we tilt them up if they can sustain it for 10 minutes. in most instances in spinal cord injury, most of them have quite fast onset orthostatic intolerance. So their blood pressure will drop certainly within the first 3 minutes. Occasionally we see people with cervical spinal cord injury that are actually able to maintain their blood pressure early on, but over time, so at the 10-minute mark, sometimes 12-minute mark, then their blood pressure starts to reduce. So it's definitely not a straightforward story. People that research spinal cord injury will tell you, if you've researched one person with spinal cord injury, you've researched one person with spinal cord injury, because they're quite different and they present quite differently. But typically our tilt tests will last 10 minutes on average.
Brilliant. There is a question from Jerome Nudi at Seawell. Is there any single stain that can reveal the size of cardiomyocytes?
That's a good question. The answer is I think I wish there probably was. If you want to look at cross-sectional area, you can probably use the wheat germ agglutinin stain. That's been reasonably well done. But if you want to be able to separate out on the longitudinally orientated cardiomyocytes, we're yet to be able to find an effective way without using electron microscopy to be able to do that. If you use electron microscopy, you can do that. But using immunofluorescence, we found that really you probably need a triple, if not quadruple immunofluorescence stain to get the longitudinally orientated cardiomyocytes.
Perhaps, Chris, I could ask if there is another cardiomyocyte related question. So the morphological and functional changes you can observe in the cardiomyocytes, to an extent, they seem to an extent, I'm saying, but resemble other kind of remodeling that occurs to the heart, for example, during cardiac failure, congestive heart failure. And there is a good knowledge, I think, although this is not quite my area, but I know, skimming through the literature, I can tell there is a lot of understanding of the changes in gene expression that may occur, for example, during cardiac failure. I wonder whether in the chronic effect of spinal cord injury, there could be equivalent to an extent overlapping changes in gene expression. What is your speculation, anticipation of this?
Well, I can share my screen again very quickly and show you that data. I didn't have time to do it because of time. But we've looked at both ubiquitin proteasome system gene expression, and we've looked at autophagy. We don't really see any changes in the markers of autophagy. But if we look at some of the E3 ubiquitin ligases that are important in this system, we actually see that most of these genes are upregulated very quickly after injury, and then they decline over the first 7 days. They never quite get back to basal levels, and actually we've done a separate study where we increased our N to be better powered, and you can still see an increased expression of the genes involved in the UPS system at 12 weeks post-injury. So we think there's certainly a shift towards the proteolytic pathways that favor cardiomyocyte atrophy after spinal cord injury. Autophagy, again, the molecular change in the cardiomyocytes is not really the strength of my lab, but we have looked at this a little bit, and the autophagy system seems a little bit more complicated in terms of the changes post-spinal cord injury, but in terms of the ubiquitin proteasome system, we have reasonably clear evidence now. We've also done the Western blots as well to confirm this at the protein level.
Brilliant. Brilliant. Beautiful data, beautiful data. I'm glad I asked the questions. Fascinating that you have pinpointed some of the genetic, if you wish, gene expression, protein expression changes. Truly fascinating. I believe there are perhaps another couple of questions from Susan Bouchard from the University of Leeds. A beautiful series of talks. Thanks so much. Your models are fantastic, allowing important and extensive data collection. May I ask Alex if there was a correlation between the extent of hemorrhage after spinal cord injury plus perfusion treatment, which was quite wide range, and the improvement in cardiovascular measures? Alex, a question for you.
That's a really interesting question. So we haven't run correlations on these data, mostly because we only have 4 points. So I don't really think we could show a statistical correlation. It would be interesting to look back and actually look at which animals had a given amount of hemorrhaging for a given improvement in cardiovascular measures. With that said, I would assume that the changes that we're seeing in the cardiovascular measures between the groups were more based on the intervention than necessarily any change in the hemorrhaging per se. I think the hemorrhaging itself will have a lot of implications for chronically what happens to the cardiovascular system. So as Chris mentioned, we're doing that longer term study looking at the animals 12 weeks post-injury. And I think in that case, we might see some really interesting relationships between the amount of hemorrhaging and sparing versus cardiovascular function in that setting.
Brilliant, thank you, Alex. I think there is time for one more question. There's a question from Sydney Valentino for Chris and Alex. Have you considered functional electrical stimulation cycling to improve venous return without upper body cycling? How do you think cardiac output will be impacted during this exercise?
Yeah, that's a really good question. So for those not familiar with it, functional electrical stimulation is a little different from the exercise we're doing. So you effectively place electrical stimulation pads over the leg muscles, and you're therefore with some training, and sometimes it can take a long time for people to build up sufficient muscle strength again to do this after spinal cord injury, but you're able to electrically stimulate the leg muscles and therefore cause active contraction. There's certainly been, I want to say probably 4 or 5 studies now that have looked at the effect of functional electrical stimulation on cardiac parameters and VO2, and all of them show that you can increase both cardiac, so venous return, and VO2 peak with functional electrical stimulation. We've stayed away from that for a number of reasons. Firstly, there's already quite a lot of evidence out there on that technology. Secondly, not everybody with spinal cord injury can do functional electrical stimulation. If there's any peripheral nerve injuries, it prevents them from doing it. There's also some reports, albeit older, that functional electrical stimulation can actually cause autonomic dysreflexia and blood pressure instability because it's a pretty severe sensory stimulus that gets into the spinal cord. And thirdly, the setup can be quite expensive and isn't widely available. And so for those reasons, we were more interested in looking to see whether we can actually get a similar magnitude of benefit with passive lower limb movement as you can achieve with functional electrical stimulation. I'll say now, having done this for the last 3 or 4 years, the passive exercise is okay. Is it as strong as the functional electrical stimulation? No, but it's probably better than not engaging the lower legs at all in exercise.
Brilliant, thank you very much. I just, mindful of the time, I think we probably reached the time available for this seminar. And before I thank the speaker, I would like to point out that and to encourage the attendees to sign up for the cardiac and vascular physiology theme or any other themes that the attendees might be interested in that can be found in the Society website. In fact, the Society is running a series of online sessions which will cover a range of really different areas within physiology. And you will find lots of information in the events page of the Society website, which I would encourage everyone to take a look at. And finally, I would like very much to thank our speakers, Dr. Alex Williams and Christopher West, for sharing with us their cutting-edge results, presentation which I found remarkably clear, not just extremely interesting, but also for me, whether I don't work quite in this area, they were especially enjoyable. So thank you, Alex. Thank you, Chris. And of course, also many thanks for all attendees and for their invaluable feedback, many insightful questions. Thank you, everyone, and I will be looking forward to meeting you all for another event of the Physiological Society. I should wish everyone a very good rest of the day. Bye, everyone, for now.